Hi, Mike Gibson, Peter Fitzgerald here live from SCAI 2015. Peter, you gave the keynote address on innovation. Where do you see the future in invasive cardiology in terms of innovation?
Yeah, Mike, it's a good question, and I think it's constantly changing. We bring new technology into the cath lab, we embrace that new technology, and we try to make sure that we're treating the right patients. Today we're busy. We've matured past, as you know, stents. We're treating heart failure in a more productive way. We're going to see a whole bunch of technology from being able to, we used to close the holes between the right and the left atrium. Today, for certain types of heart failure, especially the preserved left ventricular, we're going to be opening a shunt between the left atrium and the right atrium in order to fix some of that diastolic problems. We're going to see miniature pacemakers the size of a pill that interventionalists are going to put in, and they're going to communicate with our handheld devices from the outside. So I think we're going to get busier. I think it's going to be more precise patients that we're going to take care of. And I think ultimately for the healthcare system, we're going to do good for patients and save costs for the system.
Yes. Apple has this new initiative with, the ability to use their products to do research. How do you see that fitting in?
Absolutely, and Stanford's playing a part in that. And I think being able to, as you know best, being able to have the right people come into your clinical trials, be able to make sure that the acuity for the inclusion criteria is exactly what you want to study, rather than finding out years later that we have so many confounding variables that we didn't actually plan for the right sample size.
Right.
So having that enrichment to the patients is going to be very helpful for clinical research trials.
I think one of the more exciting things going on at Stanford is your work with, starting with Google, kind of putting the Framingham study on steroids.
Yeah.
Collecting lots of amounts of biomarker data, genomics, genetics, proteomics, terabytes of data on each patient. Very exciting initiative there.
Yeah, and actually, one of the sort of icons that you know very well, Dr. Bob Harrington, has joined our group at Stanford and really made an initiative in the fact that data are rich. We've seen this front-end data track everybody with respect to consumer-based marketing, but just imagine flipping that on the backside where we can track heart failure patients, their ethnicity, their age, their rehospitalization and why, and be able to have that at our doorsteps. Those data are going to be incredibly helpful, again, for population and disease management.
Right, if we're going to move into personalized medicine, we've got to make it personal, we've got to collect the data.
The other thing, Mike, that I talked about, which I think is a little bit out there, but I see this happening, is today we have a Gaussian distribution of what comes in our big medical centers. And we take care of not only emergencies, but we take care of a lot of urgencies. Those urgencies cause clutter with respect to cost effectiveness. We're going to see hospitals narrow up. Those urgencies are going to be sent out almost in a retail model. We're going to see the CVS's, we're going to see the Rite Aids, we're going to see the Costco have, with telemedicine, docs, really efficient blood work, because you can do it today with a little prick, just like diabetics do every day, and get your blood tests an hour later on your cell phone. You're going to see much more efficient pill distribution. So pretty much care will go out to the street corner, will go to the patients, almost like an Uber model.
Right.
And that's what's going to, I think, make healthcare, especially in our medical centers, much, much more efficient.
We have tremendous variation in the cost of all this, and how can we harness technology to minimize that variation and to deliver a more consistent product and track product through the hospital? Yeah,
I think, Mike, it's something we've always wrestled with in cardiovascular medicine and many other parts of medicine, but in cardiovascular medicine in particular, because it's one of the biggest sports, we have to be very careful about how we begin to essentially increase the a priori probability of patients as they go through the next subsequent test, so that increases the predictive value. For example, today we can, be able to examine the genome for 100 times less than we could 10 years ago.
Oh yeah, and quicker.
Absolutely. And it's going to only get exponentially less because now it's being privatized and now it's being driven by the folks that are experts at business. So we're going to be able to section parts of the room out into who has a high propensity for cardiovascular disease, so that the next test is not done on that whole population, but the ones that have a higher probability of actually having some disease entity that we need to find out. And I'm seeing a whole bunch of CT-based physiology tests that one can do with a software model and begin to find out the ones that really need to go to the cath lab. Not the ones that we go in and we have 30, 35% that are normal. The ones that really need to go to the cath lab, and actually plan that ahead of time. What size stent, what wires, what guides, what part of the anatomy to do. If the right coronary artery is normal on a CT with the physiology assessment, you don't need to shoot the right coronary artery when that patient comes in. And that has supply chain. So from the top all the way to the bottom, we ought to be able to narrow our coefficient of variation and make it better for patients and better for our healthcare system.
You know, there was a report from the Institute of Medicine yesterday that said with all this personalization and all this testing, although it sounds like we're going to spend money, at the end of the day they modeled that we would save $600 billion a year by not doing all those other things.
Absolutely, and just to get really resonant about that, if you looked at the data that has come out on percutaneous LVADs, as opposed to aortic balloon pumps for our sickest of the sick, we're actually spending more money up front, but because they're getting out of the hospital and staying out of the hospital with some of the solutions that follow those percutaneous LVADs, they are saving money. And there was some beautiful work that was done in one of the recent JACs about 6 months ago that really showed cost effectiveness. You spend a little bit up front, but you save in the long term. And I think folks, not only in our cath lab, but our CFOs in our hospitals are paying attention to that. It's not just about fiscal management, but it's about long-term cost effectiveness.
You know, we're talking about some exciting stuff you're doing with the residents. You know, where do you see us talking about earlier in disease, earlier in training people, making important impacts in terms of getting them turned on to technology?
Sure. Mike, it's great, and I think that some of us that have stayed in academics for a long time have found that the enrichment is really in the youth. They don't have as many borders to say no yet.
Right.
And so Bob and I and some other folks at Stanford are really going sort of down the experience tree, if you will, and really approaching the interns and the residents as they come into the Stanford Medical Program and really spending time with them to identify what are the things that we just sometimes take for granted, that's the way it's always done, rather than saying, well, how could we do it better? And if we could do it better, there's probably some invention in there. And certainly in Silicon Valley, once you have an invention, there's a whole bunch of incubation and infrastructure that can help bring that to fruition. So starting earlier, not with the PhDs that have run a couple companies before, but starting when the interns and the residents come in that we get to interact with and really identifying problems that need technology to be addressed to. And that's what I get excited about at Stanford.
Absolutely. Well, Peter, thank you. Thanks
Sure.
from all of us here at SCAI. It's great to have such a world-class innovator as yourself. Get up and tell us all about the future.
Thanks,
Appreciate
Mike.
it. Thanks to all of you out there for joining us here today live from SCAI 2015.